Okay. Good afternoon, everyone. It's a pleasure to welcome you to our Fairbanks Ethics Lecture Series, which we've been doing for many years. My name is Paul Helft. I'm the director of the Fairbanks Center for Medical Ethics. And I just have a few housekeeping items before I get to introduce our speaker for today. We've started to move towards text attendance, and we're putting that on hold. So for the time being, if you don't mind filling out your CE paperwork out front, you can deliver that to Annie or anywhere at the front table, and we'll take care of that for you. The evaluations will only be completed at the completion of the 2017-18 lecture series, and you'll not have an evaluation after each lecture this year. Okay, make sure you sign in, Robin says. Don't listen to anything that I said. So we record and broadcast our lectures live, and then we store them in video format on our website, fairbankscenter.org, which you're welcome to refer other people to who couldn't join us today. I also want to thank those of you who are joining us from IU Health West, Ball Memorial, North, Arnett, and IU Health Frankfurt, as well as the Child Life and Creative Art Therapies Department at Peyton Manning's Children's Hospital at St. Vincent, a new attendee as of this year. And if you wouldn't mind silencing all of your electronic devices, and there are phones just across the foyer in a little cubby just off the way if you need them. Our speaker has no relevant financial conflicts of interest to disclose. So it's a great pleasure to introduce our colleague and friend Anna Kirkman, who serves as both Associate Counsel and Director of the Medical Legal Partnership at Eskenazi Health. She's an Associate Counsel. She handles a variety of legal issues, including civil commitment hearings, employment matters, managed care contracts, hospital billing, and other exciting things, right? Federal and state health law matters. So as Director of the Medical Legal Partnership, she works to bring medical and legal professionals together to address patient social determinants of health. At Eskenazi Health, she also serves on the Ethics Committee, and to further her knowledge in this area, she completed our Medical Ethics Fellowship in May of 2017. She serves on local nonprofit boards Indy Reads, ArtMix, and the Indiana Health Advocacy Coalition. She was named by the Indianapolis Business Journal as part of the 2017 40 Under 40 class. Anna grew up in Indianapolis and currently lives with her husband and son in Butler-Tarkington neighborhood. And this is the work that she did when she spent a year with us as one of our clinical fellows, and we're just really excited to hear what you have to say, Anna. Thanks.
All right. Well, thanks everyone for coming out today and trekking through the rain to be here. We'll go ahead and get started. So as Paul said, my name is Anna, and I completed the Ethics Fellowship in May of this year. And this presentation is the product of my research on adolescent preferences in the context of life-limiting illness. So when I was putting this slide deck together, I came across this bizarre font, and if any of you have ever worked in Microsoft Office before, you've probably seen something similar. I left it in on purpose. Chronic disease and life-limiting illness in a young person and the premature conclusion of a young life is as incomprehensible as the characters on this page. It conjures up confusion, frustration. It just doesn't make any sense. Narrative and stories, however, can help us make sense of the confounding. They can help us appreciate experiences that we have not personally lived. Narrative can help providers reach a unique understanding of the patients they serve. And it's imperative that providers appreciate the adolescent's emerging autonomy and give voice to it, particularly when the adolescent's life and their ability to emerge into adulthood is cut short by illness. Narrative allows for the exploration beyond principle and medical reasoning. It encourages empathy and compassion, and it can help bring ethical principles to life, which is what I hope to demonstrate to you today. So our learning objectives are, 1, to identify at least one benefit of engaging adolescents in their own end-of-life planning. 2, to name the developmentally appropriate planning guide for adolescents. 3, to identify one way that narrative competence improves the practice of medicine. All right, I'm not sure how well you can see it. Actually, it's showing up pretty well. So my first example of narrative is a real story. It's based on the life and death of 17-year-old Ashley McHale. I saw this image a few years ago in a New York Times article, and I've never been able to get it out of my mind. Ashley used the planning guide Voicing My Choices to document her personal end-of-life preferences. You can just picture a 17-year-old with a pink pen filling out a worksheet. In this page, entitled How I Wish to Be Remembered, Ashley describes things like her funeral attire and arrangements. And when she died, she was at home as she had requested. Per her instructions, she was laid out for the funeral in her cute jeans, cowgirl boots, and white shirt she got for Christmas. At her funeral, she wanted black balloons with hot pink stars or hearts to be released. And later, after the funeral, the family dined as Ashley had requested on steak fajitas and corn on the cob. Adolescents like Ashley have sincere end-of-life preferences that are meaningful. And those wishes are not necessarily limited to clinical decision-making. For adolescents and young adults who never develop full independence on account of their illness, it's important for them to have an outlet to express these preferences and document the things that are most important to them. And now I want to turn to fictional narrative to understand the adolescent perspective on this topic. So let me introduce you to The Fault in Our Stars. How many of you have either read the book or seen the movie? Oh, wow. Okay, great. All right. So I'll just give you a little refresher. The Fault in Our Stars is written by Hoosier native John Green, and it was turned into a movie. It has an epic following among teens and even adults. And Paul Helft has told me that in his house they affectionately refer to it as Tiffios. So this really has quite an attraction to young people. The protagonist, 17-year-old Hazel Grace Lancaster, grapples with stage 4 thyroid cancer with metastases to the lungs. Her illness requires around-the-clock oxygen therapy, and one of her distinct features is the oxygen carton cannula. Some of the most significant markers in her life revolve around hospitalizations. Her disease has left her socially isolated, away from her high school peers, and constantly under the watchful care of her parents. Her only opportunity for socialization is at a cancer peer support group, where she meets Augustus Waters, an 18-year-old with a history of osteosarcoma. The two become fast friends and relate on an intellectual and emotional level. Before we start a couple movie clips, I want to highlight some of the unique features of adolescents with chronic and life-limiting illness. There's general consensus that adolescents between the age of 12 and 14 have the cognitive ability to consent to care. Children as young as 8 can begin to grasp the permanence of death, and 10-year-olds with advanced cancer can comprehend end-of-life decisions. And this is a quote from an older Hastings Center report, but still relevant. They have had, at the very least, multiple opportunities to think about the inescapable suffering that characterizes their lives, the features of life that make it worth continuing, and benefits and burdens that accompany medical treatment and the prospect of death. And so this quote is a really great segue into the first clip we're going to watch here. All right. So this is about a 10-minute clip, so enjoy. Okay, the volume's not working. All right. Okay. Give me just a second. I would have brought popcorn for everybody. All right, so I think what we'll do is I will read a piece from the book for this particular segment, just so we can keep things moving. All right, so Hazel and Gus meet in support group, and Gus pretty much asks Hazel what her story is, and here's what she said. I told Augustus the broad outline of my miracle, diagnosed with stage 4 thyroid cancer when I was 13. I didn't tell them that the diagnosis came 3 months after I got my first period. Like, congratulations, you're a woman, now die. It was, we were told, incurable. I had a surgery called a radical neck dissection, which is about as pleasant as it sounds. Then radiation. Then they tried some chemo for my lung tumors. The tumors shrank, then grew. By then I was 14. My lungs started to fill up with water. I was looking pretty dead. My hands and feet ballooned, my skin cracked, my lips were perpetually blue. They've got this drug that makes you not feel so completely terrified about the fact that you can't breathe, and I had a lot of it flowing into me through a PICC line, and more than a dozen other drugs besides. But even so, there's a certain unpleasantness to drowning, particularly when it occurs over the course of several months. I finally ended up in the ICU with pneumonia, and my mom knelt beside the bed and said, "Are you ready, sweetie?" And I told her I was. And I remember not wanting to be awake. Okay, so I will keep going with the PowerPoint. Oh, okay.
We can write it off up here.
Okay. All right. Sorry for the technical difficulties. We practiced this like no less than 3 times to make sure this would work, and still it's not. So engaged in terminally ill adolescents and end-of-life planning supports their emerging autonomy. And when surveyed, teenagers said that not being able to express end-of-life preferences would actually be a fate worse than death. Avoiding these discussions denies dignity and can further isolate an adolescent who may be withdrawn from school and social activities. So if we can get it going, I've got a clip for this segment.
Which slide were you on?
I think it was
That one?
one of the next one.
The next one?
Yep.
Let me do this real quick.
Lymphoblast.
Watch for that window.
Okay, all right. Okay. So I am going to show you, let's see, how are we on time? I'm going to go ahead and show you that first clip. I think we're okay, and I think it informs the rest of the discussion.
Leukemia.
One more. Okay. So in that clip, we saw Hazel, again, talk about her personal experience with cancer, what treatments she's endured, her pain, her discomfort, her near-death experience. And those are experiences that she has personally lived and is sharing. Other elements that we pick up on in that clip are the push and pull between independence with Hazel as an adolescent and still relying very much upon her parents for everything like driving and care and watching Top Model together. Her social life revolves around her parents at that point too. We hear her talk about how she got her GED, so she's unenrolled from high school. She's isolated from her peers. We get the sense also that her mom's life revolves around Hazel. And we also hear her talk about her decision to go to support group, and other decisions she makes is based largely in part about what she thinks will make her parents happy. And so those are some insights into sort of her unique perspective. All right, so this is kind of where we were. So this goes into adolescent autonomy and really adolescents wanting to assert decision-making in this process. So we're going to fast forward a little bit in the film. Hazel and Gus have developed a friendship at this point. They have some shared interests, including a favorite book, and they're entranced by the author of the book, and they want to go to Amsterdam to see that author. All right, so in that clip, we saw Hazel really asserting her independence, her autonomy, by showing her determination to go on this wish trip. She knows she's dying. Of course, there are risks wherever she turns, but she has a strong preference here to take advantage of this opportunity to go on this life adventure that she may never have another opportunity to do. And she really wants to make decisions about how the rest of her life will be spent. So what are the benefits to engaging adolescents in this decision-making process? For adolescents, they report positive emotions following discussions. The process demands transparency from the treatment team, and they feel that they're taken more seriously by their parents and caregivers. There are benefits to providers as well. They feel that they have clear and documented guidance. They may see some improved compliance because the patient's invested in the plan. And there's the sense that it builds rapport with the family. And for parents, there are also benefits. Although parents may be reluctant to approach these topics, they express feeling a sense of relief, and they can rely on the substituted judgment or what their child would want and avoid making uninformed decisions that they may later regret. So we're going to do another movie clip here. And we'll see if you can kind of extract the benefit, kind of what you see as benefits here. All right. So even with an 85% chance of survival, Gus wanted to pick out the suit that he would be buried in just to make sure he identified it and that his parents knew what he would want. And to go back to this benefit to adolescents, he may have had some sort of positive reaction to the ability to express that wish. And also his parents would know exactly what he wanted. Again, a benefit to his parents as well. A couple of other elements of this clip that are worth highlighting. So this allows us to see that, adolescents want to explore romantic relationships. And so at a time when they're learning about attraction and sexual feelings and their connection to others, for those with life-limiting illness, they're at the same time being pulled away from those experiences and opportunities. And so we see that Hazel and Gus are both really sharing in this opportunity to spend time together and get to know each other romantically. And they talk about being on a date, and you can kind of just tell from their body language. And then we also can see how much value they get from experiencing the firsts in their lives. So the first champagne that they're having. You can think of other firsts. Earlier in the movie, when they're flying to Amsterdam, we learn that it's Gus's first flight. So what kind of firsts might adolescents want to experience if they know that they aren't going to reach adulthood? So those are the benefits. The challenges we see is that are that cognitive development may actually be stunted by having to spend significant time in the hospital or away from school because of illness. Adolescents have had fewer life experiences, and so they may be inclined to choose more medical interventions than their adult counterparts. And they may even seek more aggressive care in an attempt to please their family members or as a result of pressure from treatment teams. So what do adolescents want? They want to participate in the decision-making process. So a study involving 25 chronically ill and 25 healthy patients ranging in age from 13 to 21 were asked if they wanted to participate in end-of-life planning. 96% of those who are chronically ill said yes, and even 88% of healthy adolescents said yes. Their priorities were driven by many things, namely concerns about pain, the impact that the experience might have on their family's finances, and the emotional effect on their family. They were focused on legacy and memory making, and they might make decisions, again, based around the idea of firsts. So as life goals such as graduation, wish trips, and school dances. This is the last clip I'm going to show here. I think we're okay on time. So in this clip, the narrative has changed quite a bit. All right. And Gus has learned that his cancer has returned and spread. He's pretty rapidly deteriorating, and he gives voice to some more profound end-of-life preferences.
We are.
Hazel gives a nice speech too, but I want to save enough time for questions at the end. So in that clip, we see that for Gus, it was really important for him to understand his legacy and what he was going to be remembered for and how he was going to be eulogized. We also see a really important dynamic between Hazel and her parents. So just as 93.4% of chronically ill teens worry about the emotional effect on their family, Hazel is deeply concerned that her parents are not going to want to go on after she dies. And so when she finds out that her mom's been going to school for social work, she's elated. And so it just kind of reinforces that concept of this communication works both ways. Hazel gets a sense of relief knowing that her mom is pursuing something else. All right, so now I want to go back to the Voicing My Choices. This is a document, a planning guide that was created by researchers. It was released in October of 2012, so it's been around for precisely 5 years, and it's a developmentally appropriate planning guide designed for adolescents and young adults. They can talk about legacy, who they want to give their personal belongings to. It gives them an opportunity to write a letter to their family. It has a glossary of medical terminology for their reference. And it lets teens describe when and what visitors should be allowed. If they want to be woken up when they have visitors, dressed, etc. They can go on and talk about music and food and other things that are important to them. Oops. And this is my final story, my personal one. So halfway through the ethics fellowship in this project, I was diagnosed with breast cancer. The top left picture was taken March 2nd of 2017, my first round of chemo. My illness was not life-limiting. It provided an opportunity and an opening to talk about advanced directives. My husband and I drafted a will, and so on. But in the process, I identified some of my own authentic preferences. I share these pictures because my personal coping strategy was having a themed t-shirt for every round of chemo, as if somehow that thin layer of cotton was going to give me strength. So, fight like a girl, grace with grit, I rise, I rise, I rise. And I can't help but think back to Ashley McHale's wish to wear her cute jeans. And I fully appreciate how something that seems trivial, like clothing, can be quite empowering. End-of-life discussions often do not occur until a medical crisis arises for fear of taking away hope. But that contrasts with empirically based research that early palliative care can instill hope, maintain psychological well-being, increase congruence in treatment preferences between patients and their surrogate decision makers, prolong survival, and improve the quality of life and mood among surviving relatives. And adolescents, believe it or not, have even an opinion about when these conversations should happen. So this is a graph that shows that 32% of teens with chronic illness wanted to have conversations at the time of their diagnosis, 32% at the time of their first illness, 20% at first hospitalization, and 16% at the time of dying. So you can see that the majority, 64%, really would prefer to have these conversations early on, and that supports that previous quote about having this dialogue early in the process and not waiting for crises. So this is a final quote from The Fault in Our Stars. Gus aptly declares that the world is not a wish-granting factory, and he says that when he finds out that his cancer has returned. So when adolescents were asked about a previous iteration of the Voicing My Choices form, it was called My Thoughts, My Wishes, My Voice. And the teens who were interviewed told researchers that their, quote, wish would be not to die. The word wish was therefore removed from the title of the planning guide, and that's how we got Voicing My Choices. So in the end, you may or may not be able to grant the child's ultimate wish, but there are some smaller wishes that you may be able to honor for an adolescent with life-limiting illness. I want to thank all those who supported me and have supervised me in this process, and I'm happy to take questions. So I'm going to actually turn that question back to the audience. I'm an Eskenazi employee, but I think that we have some Riley palliative care and child life.
Hi. Okay, sorry. I know that Little Red Door has some groups, and I go to cancer support community, and they do more for adults. And we have a parent group here once a month, but nothing to my knowledge for adolescents.
Thanks so much for your presentation. I am a pediatric oncologist, so we deal with these situations quite a lot. And recently we implemented Voicing My Choices in our adolescent patients that are getting ready to come to stem cell transplant. And I think it has been overall really well received and has been helpful in conversations. But one challenge that we have encountered that I don't have a great solution for is part of Voicing My Choices allows the adolescent to declare what they want their code status to be. And by nature of coming into transplant, you're full code. So it has been challenging to allow them to voice their choices and then tell them that they can't be, like we wouldn't allow them to be a no code coming into transplant knowing that we would need to support them. And we usually, it's surprising to me how many times adolescents will say that they want to be DNR. And so that has been a challenge for us. And we usually ends up in having, I think ultimately the outcome is still good because we have a conversation with them about that if a child wishes or an adolescent wishes that they want to be no code. But it's hard to medically relay that there are different contexts for which when we would be talking about code status. And so I don't know if you have any guidance for that or thoughts about that, or if anybody here has any thoughts about that, because that's one challenge that we have encountered.
Are there other parts of the guide that are still useful to you? I mean, could you just leave that part out temporarily and have them revisit it when it's more appropriate?
Yeah, I mean, I think across the board, it has been helpful for starting a conversation, and maybe that's the most important take home is that it starts a conversation about what their choices are. But I think this is me projecting my impression on the adolescents that I've worked with on this, but I think it's a little challenging to say to them that you get to voice your choices, but not about that, right? Like, so I don't know. I don't have
the choice is the transplant, right? So that's the larger choice that they're making, correct?
So usually when we're using this tool, it's when they've already decided to come to transplant. And it gives us a framework for how we approach conversations with them and how we prioritize their goals. But specifically what I'm talking about is to tell them that they get to voice their choices and then tell them that they can't be DNR.
Right. But they're already coming to this, making the choice that they want to pursue the transplant. So I think it's just a boundary within that bigger choice that, you have additional choices within that. Choosing DNR or CPR just isn't one of those for the purpose of this process. And I think just eliminating the question, then it's not an issue of then trying to take it back from them once you've offered it. There's nothing that says, you have to complete every question that's offered in the guide, certainly. Yeah.
Does religion have an effect in these adolescents and how they choose whether they should know or not for the NDR, for example?
So the question
does religion have an effect on these adolescents, on the decision they will make?
It's probably an individual. I mean, I did not research that particular question, but my sense is plays out individually for people, and that, there are some thoughts on who might help the adolescent complete the guide. So the instruction or the guidance is that they shouldn't do it on their own. So perhaps having a trained chaplain or religious provider would be the best person to help that adolescent through that process if that's consistent with what the adolescent believes.
I have one more question. It's coming from one of the broadcast sites in just a second. She just texted and asked if she could ask a question.
Okay.
So. Hopefully she's going to ask it quickly.
So much technology. Anything else while we're waiting?
It may have to wait. So I may have to ask
respect for the 1 o'clock hour, Anna, would you be willing to stick around for
Sure.
a couple more minutes in case anybody would like to come up? If not, I'd like to thank Anna for her.
Thank you.